case for just integrating the neurology and getting to think about how you use frequencies to do what we do. The first thing I want to talk about is the resonance effect. The book is doing really well, the reviews are great, and I just want to remind you to spread the word about what you do, why you do it, and how well it works. That's why I wrote the book. I suggest you buy some additional copies and loan it or sell it to patients. People love the story. That's been really fun to see. And its major purpose is to build an awareness about FSM and the frequency effect so that patients can spread the word about why they're your patient and what you're doing for them. So just a reminder, Amazon carries it, or you can buy it from our website if you want a signed one, but Amazon actually has it for less than we do. However you do it, that's spreading the word about FSM is really helpful for everybody. So we had the June webinar patient. She was the one that had been in a wheelchair for 8.5 out of the previous 10 years. She'd had abdominal bloating, like her girth would increase by 6 inches while she was just sitting there doing the history. She had appendicitis, a ruptured appendix. At the age of 19, she was 38. She had managed to get pregnant through all of these abdominal adhesions and body pain and all of that. She had 3 children, and she arrived in a wheelchair, accompanied by her husband and her 3 kids when I saw her, I think, in June. She arrived on July 10th for her follow-up appointment by herself. No wheelchair, no husband. Her husband and her kids were at home in Idaho. But she caught a plane, made her own reservations. Nope, you just muted it. No. Okay. You want the volume up?
Turn your speakers off.
Pardon?
I just want to turn your speakers off.
You want my speakers off? Okay. That doesn't turn the mic?
No.
Off? Okay. So she arrived for her July 10th follow-up on a plane by herself, no wheelchair, no assistance. She was beaming. If you recall back from June, the original problem that caused her to need to be horizontal was probably adhesions in the vagus nerve and abdominal adhesions. So when she arrived, her pain was only a 7 out of 10. Her abdominal pain was a 5 out of 10, which was so much less than it had been for 18 years previously, that she was a very happy camper. Turns out that her body pain diagram was the typical 40 and 10 diagram. So we did neck to feet, 40 and 10 for 40 minutes, and her body pain went to a 0. Her abdominal pain was mostly secondary to adhesions, 13 and 77, the bile duct, the small bowel, the ascending colon, and the cecum were what were still adhered. And then it turns out that her low back pain was mostly secondary to really tight QLs, very tight, very tender on the left side of the low back. I treated scar tissue in the ureter, scar tissue in the kidney, and then that sclerosis in the adipose, the fat pad around the kidney. And there was still, the abdominal pain got better, but her lumbar spine pain, the tightness, was still really a feature. And like the only thing that causes pain there is kidney stones. So I did 20 and 60, and sure enough, the kidney stone pain went away. So that was quite an event. Then the left lower quadrant, as I came medial a bit, it turns out that It was very superficial, and I asked her where she was in her menstrual cycle. She just finished bleeding the week before. Felt awfully suspiciously like an ovarian cyst, so I did 40 on A and 7 on B, and that did indeed take the left lower quadrant pain away. So she had right lower quadrant pain from the ascending colon, the small bowel, and the ureter, and the left lower quadrant pain was from an ovarian cyst. She had neck and headache pain, and her jaw pops, so I did 40 and 94 to quiet down the upper trap and the FSM, torn and broken in the ligaments, the tendons, and the connective tissue to help with the jaw muscle tone, and the popping was reduced. The TMJ is going to be another issue. Then we did neck to feet with her seated. She still had restrictions in motion and a sense of tightness. So I did scarring in the dura, scarring in the cord. And at first she could only bend forward maybe 10 or 15 degrees. At the end of it, she could make her spine into a C and reach down and touch her toes. So there was a lot of giggling going on at that point. It was pretty fun. On the month before in June, we sent her urine mold test off to real-time laboratories because her symptoms had been worse or better depending on the house she was living in. And that usually is associated with mold. So the mold test came back. It was positive for Stachybotrys, which is a neurotoxin. She was started on chlorella, and I told her to see her MD, DO, her osteopath, for cholestyramine, and also to have her MD or her DO prescribe a compounded nasal spray for the sinus issues that she has, and this might also help with the headaches and the jaw pain. So she left with a custom care program for 40 and 10, and the gut issues, and the mold issues in the sinuses and the vagus nerve, and her pain remains 0 out of 10 on most days. So the mold nasal spray formula, this was, I think I got this from Werner Vosloo or Neil Nathan, could be either one. It's a mold nasal spray formula that handles fungal infections, mold infections in the sinuses. Amphotericin B is not taken orally anymore. It's pretty toxic. But when you use it topically in the sinuses at 0.25%, it's an antifungal. It's really effective. It's not absorbed. And I've been on this concoction for about 2 years, and my sinuses are finally clear. EDTA, 0.75% to dissolve the biofilm. Mupirocin, M-U-P-I-R-O-C-I-N, it's an antibiotic, 0.2%. In 30 milliliters of sterile water or saline. So it's for 30 milliliter final volume. Or you can also use, if you don't have prescribing privileges, you can also use Argentin 23, which is a silver, it's not colloidal silver, it's a silver solution nasal spray. There are no resistant strains to silver, so it will take care of bacterial as well as fungal infections, and doesn't do anything for the biofilm, unfortunately, but it will help with the infectious agents. So that's what I sent her off with. Okay, so this case that is the July webinar. Was really complicated and kind of scary, but it ended up being easy, actually, in the long run. But you'll get to decide that yourselves. She's a 30-year-old, very quiet-spoken young woman. She was accompanied by her mother. She was using a Segway. It's a lightweight version of a Segway. She called it a bot. Or she could use a walking staff for mobility because she had a spastic muscle weakness type of gait. Her history was she had a neuroblastoma at the age of 18 months that was misdiagnosed as cerebellar ataxia for 1 year. Neuroblastoma is the most common malignant tumor in children, and they missed it. So at about 2.5 years of age, she had surgery to remove this tumor. Mom said it was between the dura and the spinal column. Could also have been between the dura and the cord. She wasn't clear about that. Anyway, the surgery was between T2 and T10. So her spine was kind of open. They unroofed it to take out this tumor. This was at age 2.5. She had a return of symptoms at age 3, 3.5 in there someplace. And so she had radiation to the spine at the age of 3. So the cancer went into remission, which was extraordinary. They weren't entirely sure she'd live to adulthood, but she did. It went into remission. There was no recurrence. Radiation is particularly effective for this type of cancer. So her history continued with developmental delay as she grew up, problems with balance and gait. She had multiple falls because of the problems with balance and gait. She had head injuries. She wore a helmet when she was walking around, playing around. But at the age of 8 or 12, she started having abdominal migraines. The symptoms were burning in the abdomen, the solar plexus, the stomach. I swear to you, in an 8-year-old, 10, 11, 12, in there someplace, who'd had radiation between T2 and T10, some internist told her that she was seeking attention. Anyway, so she's had so the abdominal migraines continued. She had menstrual difficulties as a teenager. Mind you, her pain level during this period, her pain is never below a 6, 5, usually between a 5 and a 9. She has difficulty with temperature regulation, which is characteristic of spinal cord injury patients, because the temperature pathways and the autonomic pathways, regulatory pathways, especially in the thoracic spine, go through the spinal cord. So between the surgery and the radiation, you could expect the spinal cord to have issues. She had hip surgery in 2005 for calcification of the left hip labrum and tendons. If you think about the amount of yanking on the tendons and the joints that are created by the spasticity, this is not terribly surprising. So they took out the calcifications, did not do a hip replacement, did not do anything except clean up the bone spurs. She has recurrent bladder infections secondary to not emptying her bladder fully. Once again, this is characteristic of spinal cord injury patients. So the pattern that you see is that is characteristic of patients with spinal cord injuries, right? She had a spinal cord stimulator put in maybe 10 years ago. They really honestly weren't clear about the date. The spinal cord stimulator was used to keep the pain down. It did not have any effect on the spasticity. So if you can visualize a gait that is someplace between an ataxic gait and the kind of gait you see on a patient with cerebral palsy. So she's slightly less spastic than a cerebral palsy patient, and she has a degree of weakness, kind of a Trendelenburg, glute medius kind of collapse weakness situation, and spasticity all at the same time. She's on buprenorphine twice a day for pain, Cymbalta for pain and depression, gabapentin, 300 milligrams as needed for neuropathic pain, and then Bactrim as needed for the bladder infections, and she was currently on Bactrim when I saw her. She had migraines and abdominal migraines, and she was on feverfew to prevent the abdominal migraines. She took migraine medication as needed when abdominal migraines occurred. So what does this tell you about her pain, and what does this tell you about central sensitization? So the fact that she's been in pain effectively since she was 18 months old, that is an important piece of this. So she is going to have pain that is spinal cord mediated. She's going to have pain that is centrally sensitized. And in addition, she'll have peripheral pain from the muscle spasticity and from the joints being yanked about. So the spasticity is something to consider in addition to the neurologic component to the pain. Buprenorphine it's an opiate, and it would be useful for the joint and muscle pain. Cymbalta they use for central sensitization and central pain, and then gabapentin is also for neuropathic pain. Okay, moving along. So the initial pain diagram just showed pain in her left hip and down her left leg to the foot. And then I listened to this history that included spinal cord surgery, radiation to the spinal cord, looked at the spasticity. Given her hour-long and complicated history and gait, there was no way that the only pain she had was in her left hip and leg down to the foot. So I had to go take a phone call. I handed her back her pain diagram, and I said, I think you probably left out about 60% of what actually hurts, because I suspect you don't think there's any way I'm going to be able to help you. So if you do me a favor and actually finish filling out the pain diagram, put in everything that hurts. Well, the accurate pain diagram included pain in both feet, the chest, both arms, the sacrum, the back of the neck, the back of the head, and her abdomen. It was basically a 40 and 10 pattern with additional pain strokes or pain. She filled it in more in her chest and her mid-back. Initially, Mom did most of the talking for the first 45 minutes, and then the patient opened up a bit. She had been pretty poorly used by the medical physician she'd seen, and I don't know that it was her fault or their fault. I don't know that it was their fault. It's just that they didn't have any way to help her. So they were not, most of them, overly kind. Doctors told her that her abdominal migraines were on her head and she was seeking attention. I swear to you that with a history like this, with the spinal cord and the radiation, they had been told that no one knew why she had such an odd gait. I don't understand that. Maybe somebody can explain it to me at some point. But from the time she was 3 years old until she was 32, no one had been able to get her pain below a 6 out of 10. Judith Aston she met, and they worked with the muscle and fascia and did Aston patterning, and that actually helped, but the pain was never below a 6. Physical therapy helped, but the pain was never below a 6. Functional medicine helped. She was on a clean diet. She was gluten-free. I don't know if they did testing, but she said she's on a celiac diet, and apparently that had helped reduce the abdominal migraines. What's interesting about this pair, this mother-daughter, is they kept looking for help, and they kept her as active as she could be. She's very determined. She's tough with a pain level as high as that. They still went on hikes and on various trips, and she was halfway through, 20 hours or more, bachelor's in psychology. She wants to be a counselor. So that's what we had going into the beginning of the treatment portion at the end of the history. The patient's affect was, she was quiet and withdrawn. She didn't make eye contact easily. If you've ever had pain level of an 8 or a 9, you'll understand that emotional interaction and contact is not particularly easy. So after the pain diagram and before the physical exam, so I'd already gotten the pain diagram back. She happened to look up, and I moved my chair, so I was about 3 feet from her and made eye contact with her. And I said, "Nothing you have scares me. This is not in your head. It never was. It is real. And none of this is your fault." And she started to cry. I have to say that the reason I made these statements is because she needed to hear them. I didn't mean to make her cry, but I wasn't surprised that she did. She looked at me and she said, "I scare doctors because they can't help me, and they told me it was all in my head." So that actually makes sense, right? When you have a patient that you can't help, even with FSM or in any other realm of your clinical skills, there is a tendency, because we feel incompetent, because we're not able to help, because we feel threatened, if you will, that some physicians tend to make it the patient's fault. Anyway, so all of this started when she was 3, and children think they cause everything. 3-year-olds, it's magic. It's magical thinking time. So she had always thought someplace inside that this was her fault. So going into the treatment, when the pain starts at an early age and lasts this long, think about it, it's like a fibromyalgia patient, right? When the pain is this high and lasts this long, the thalamus changes from pain suppression to pain amplification. Intense pain in any patient increases corticotrophin releasing factor. It's a stress hormone in the brain. Corticotrophin releasing factor interferes with short-term memory and cognition. And CRF predisposes you to only remember how you got away from the tiger the last time. So corticotrophin releasing factor goes up when the pain is so high that your body figures out that you're running away from a tiger in the woods and you've got maybe 20 minutes to live. You don't have to remember anything else that happened. You don't have to think about anything else. The only thing you need to remember is how you got away from the tiger the last time. And the way this looks in a patient is reflected in what I said to her next, because she needed to know that she wasn't crazy. Making eye contact again, I said, "I don't mean to rat you out to your mom, but there is something that you don't tell anybody. You can remember every bad thing that has ever happened to you in intense and immediate detail, as if it happened yesterday. And you might even think that you're crazy because that's what you think about." And it was a guess on my part, but that's the way elevated CRF acts in the brain. And she started to cry again, so it was a pretty good guess that this statement was correct. You don't want to tell anybody that the thing that you think about is every bad thing that's ever happened in your life. She started to cry again, and I said, "It's not your fault. It's simply what your brain does when you're in this much pain for this long." So recognizing what CRF does in the brain is useful for the patient because they think they're crazy. If you get flashbacks all the time of every stupid, bad, painful, uncomfortable, emotionally or physically difficult thing that ever happened to you, you kind of think you're crazy. So that was a relief to her. So at this point, we've already started the conversation to prepare her for what was coming. Helping her emotional and mental state was almost as important as helping her body, because I wasn't entirely sure that I could help her. "Nothing you have scares me. This is not in your head, it's real. None of this is your fault." So the physical exam, I have to say, was very abbreviated. I ran the pinwheel across her left and right C6 dermatomes and the right C6 pizza cutter sensory wheel created clonus in her right arm. Her patellar reflexes were very hyperactive on the left and created 3 beats of clonus on the right, suggesting that the left side of the spinal cord at the thoracic level was more involved than the right side, since those pathways cross. Characteristic combination of muscle weakness and spasticity in the gait. So my diagnosis working into this was spinal cord damage to both the sensory and the motor pathways. So loss of descending inhibition of spasticity, loss of descending motor input, and damage to the anterolateral pain pathways, leading to 40 and 10 kind of fibromyalgia pain, or effectively central pain, because of damage in the spinal cord. Following the radiation, adhesions in the thoracic, perhaps even the lumbar and cervical nerves, and the dura secondary to the surgery and the radiation. The patient was not ambulatory secondary to due to the spasticity, and she had her bladder empty, and she was treated supine for 2.5 hours. So she made the transfer from the interview chair to the table, seated for the physical exam, and then I laid her on her back. So I had to borrow a 4th unit. I had to borrow an additional unit from the folks at New Heights. Unit number 1 was to run 40 and 10 from neck to feet to reduce the pain. But if you use 40 and 10 by itself, it'll make the spasticity worse. If you haven't ever done this, it was a bit of a shock the first time it happened. I got the patient's pain down. It was a transverse myelitis patient. So 40 and 10 made the pain go down. I couldn't understand why her hamstrings hurt, but her hamstrings hurt because her hamstrings became spastic. The second unit was run on 81 and 10 from neck to feet to reduce the spasticity, but if you used it by itself, you'd make the pain worse. So she had 2 units, Unit 1 and Unit 2, running from neck to feet, one running 40 and 10, one running 81 and 10, and no, I had never done this ever before in 22 years of treating patients. I didn't know how it would work, so I started 40 and 10 first by about a minute, and then started 81 and 10, and ran both of them together. The spasticity started to be reduced. The pain started to go down the way 40 and 10 always does, like from neck to feet. Sorry, the pain recedes from the feet up. And they had to be used at the same time, both at one time, in the same towels, 40 and 10 on one machine, 81 and 10 on the second machine, in towels at the neck and the feet. The nerves out on her chest and her abdomen, and down to her leg. Remember, she had that left leg pain. So unit number 3 ran from her spine, so I had a towel going from her sacrum up to T1, and the negative leads from that unit were down on her left leg for the leg pain, 40 and 396, and then scarring in the nerve and scarring in the dura for the leg pain. So if the nerve is scarred, right, 40 and 396 made sense. And then back and abdomen, I had an auto care on her with washcloths on her spine and on her abdomen. Ran the concussion protocol for what's that, 36 minutes, and then on that unit went to, I think, thalamic pain syndrome or the nervous system section. I think it was thalamic pain syndrome in the pain section, or the nervous system section for the medulla, and I did 40 and 89 and left unit number 4 on 40 and 89 once the concussion protocol was finished, 40 and 89 for another 60 minutes. And this unit number 4 and 40 and 89 is probably the only thing you'd have to think twice about. So if you have been in pain for 5, 10, 15 years, the thalamus will be completely confused if you become pain-free. If you can imagine being 32 years old and having been in pain for 30 of those 32 years, imagine the condition of her thalamus when it came to pain. So 40 and 89 ran for 60 minutes, at least, maybe more. At 60 minutes, the body pain was 0 out of 10. And I kept running 40 and 89 because you can imagine that being out of pain would have been a little bit disorienting. So then the next task was to address the dural adhesions. Mind you, this is still treatment day 1. So July 5th, treatment day 1, we're about an hour and 20 minutes into it. I switched one of the units, the 81 and 10 unit, from 81 and 10 to scarring in the cord and then scarring in the dura, and asked her to tuck her chin to a bit, just tuck your chin a bit. And when she tucked her chin, she had pain in her left foot and in her chest. That tells you something, huh? And then pain in the left side of the skull. The only thing that would cause pain in your foot, your chest, and inside your skull when you tuck your chin towards your chest is the dura. It's the only thing that runs or is connected to nerves to your foot, nerves in your chest, and inside your skull. It's the dura. So scarring in the dura, 13 and 443, while she created movement with her chin, tucked her chin to her chest, took a deep breath, turned her head from side to side, took a deep breath, a little bit of mild Valsalva, and that started to improve. Did a little bit of cranial sacral adjusting while I ran 13 and 443, scarring in the dura. And then remember, she had unit number 3 was on her feet, spine to her feet. I palpated her ribs between T3 and T6, and they were exquisitely tender. So I took unit number 3 and moved the black and yellow leads from her feet to her chest. So I warmed up a hand towel and put that along the length of her chest, ran 40 and 396 to just quiet down the nerve pain, because ribs are not just ribs in the thoracic spine, they're intercostal nerves. So I ran 40 and 396 to quiet down the nerves. And then 54, if you recall, is the frequency for radiation. I think maybe that's the only one that we have from the advanced in the sequence. So 54 is radiation. What got radiated? The spinal cord, 10, 443 the dura, and 396 the nerve. So we ran remove radiation from the cord, the dura, and the nerves, and then started running 13, scarring in the nerves, scarring in the dura. And while I was running that, had her take a deep breath and flex her trunk and rotate just a little bit. Every time the rib pain or intercostal nerve pain increased, I went back to 40 and 396. So if you look at taking the scarring out of the nerve and the dura, you can do just about anything you want, because if you jack things up, if you pull on the nerves or tug on something that's going to increase pain, you are in a position to decrease the pain virtually immediately. So we ended up having to use 40 and 396 for 30 to 60 seconds to maybe 2 minutes on and off during this increase in range of motion. Unit number 4 stayed on 40 and 89. This girl is out of pain for the first time in 30 years. It's a thing. It's disorienting. So that's where we were. We're still on day 1, mind you. Now, I had the ability to see her. She was my only patient for that day. So it's a little bit of a unique situation, but it shows you what's possible. And I'm more interested in having you understand the mechanisms behind what we were doing and how everything worked. Because if she'd been a local patient and I could see her 3 or 4 times a week for a month, we wouldn't have had to do this all at one time. As it was, I had her for 3 days and actually a fourth day. So unit number 1 was still neck to feet. Unit number 2 was still 40 and 10 from neck to feet. So I moved up to sitting at her head with my hands on her upper neck, kind of like we do in the supine cervical practicum, right? So I changed because this pain diagram was the back of her head and her neck, which is ferocious. So I changed unit number 1 with neck palpation to scarring in the dura, that space where the dura is adhered to the rectus capitis posterior minor, right? And the nerves and the dura. So scarring in the dura, scarring in the nerves, and then torn and broken in the alar ligaments and cervical spine ligaments up at the upper cervicals. So we played around with this for probably 20, 30 minutes and came along, except that right at the base of her skull, it was just resistant. And 13 and 396 should have worked and didn't. 13 and 443 should have worked and it didn't. And all of a sudden, our cadaver from chiropractic college came to mind, and he had adipose and fascia, fat-lined fascia at the base of the skull, where there's little teeny bubbles of adipose that are glued to the fascia, and that was glued to the nerves. So 3 and 97, I told her that I was treating the bubble wrap at the base of her skull. So sclerosis in the adipose. If you think of the adipose-lined fascia that's at the base of the skull, I'll give you an idea what it felt like. That just melted it. So the upper part of the neck down to about C3, 4, 5 was now mobile and more or less pain-free. She still had the pain inside her skull when she tucked her chin. So we did scarring in the dura with cranial adjusting. So I had her do gentle Valsalva maneuvers to expand the dura inside the skull, tipping her head from side to side to sort of tug on the dura to get rid of the adhesions between the dura and itself. The skull normalized, and as she tucked her chin then, her sacrum felt tight. So where does the dura attach? Inside the skull, at the foramen magnum, and down at the feet. So and down at the sacrum. Lines the sacrum on the medial side of the SI joints and then down to the tailbone. So the sacrum felt tight. So I switched unit number 1. Unit number 2 is still on 40 and 10 from neck to feet. It's so important to keep her pain down. Unit number 2 went to 13 and 443 with the black and yellow leads at her feet and scarring in the dura. And so I rocked her hips, so brought her knees, flexed her knees, and rocked her hips to the side, and she could go about 10 degrees to the left and about 20 degrees to the right, so she had almost no rotation in her thoracolumbar spine and her pelvis from side to side. So the dura was adhered from the radiation damage, probably in the thoracic spine, but also just because of lack of mobility, probably in the lumbar spine, the sacrum, and the tailbone. So started just flexing her hips. You go up to a place where it gets tight, hang out there for a minute, straighten the leg out a bit, go back up, and each time the range of motion, just in flexion, improved, and then I started rocking the hips side to side. At the end of it, both directions, with her knees flexed, you could tip her knees over to about 45 degrees in both directions after about 20 minutes of scarring in the dura. So you may never see a patient like this, but you will see patients with adhesions in the dura that show up as pelvic motion restrictions and motion restrictions in flexion and rotation in the hips, the pelvis, and the lumbar spine. So what connects the pelvis, the sacrum, the coccyx, and the hips to the rest of the spine and the skull? It's the dura, right? So scarring in the, think of scarring in the dura when you see this kind of restriction of motion. And the trick with this is go right to the edge of where it feels tight, then back off, and then move to where the restriction is again. If you could see my hands move, I'm Italian, right? So I'm doing this motion with my hands. But it's gentle motion right to the edge of tightness and then back into neutral. Unit number 4 was still running on 40 and 89. Her thalamus had to be constantly quieted to keep it from looking for the pain, because she was out of pain for the first time in 30 years. Unit number 1. Now, we are still on day 1. We're approaching the 3.5-hour mark, 2.5 hours of treatment. She needed to be able to move actively and connect this body that now moved differently than it had ever moved. Ran 81 and 84 and had her flex her ankles, flex her hips actively, resist ankle flexion. So bring your foot up, now push my hand down. Push your toes down, now pull my hand up. So you give them a little bit of resistance, so they have to activate the muscles. Resisted ankle flexion, dorsiflexion, resisted neck flexion, tipping your head back into the table, tipping your head forward while we're running at 81 and 84. Her cerebellum has absolutely no idea where these muscles are, what they're supposed to do. So the cerebellum, 81 and 84, increased secretions in the cerebellum to get it to coordinate movement. And then 81 and 92, it's an odd sensation when the patient can move an area but literally doesn't know where it is. 81 and 92 was essential because these muscles in our body have only been represented in the thalamus, only represented in the pain centers. Should know or very little awareness of where they were in the sensory cortex. So 81 and 92 with active movement. And we bounce back to 81 and 84, increased secretions in the cerebellum, then back to increased secretions in the sensory cortex. And as a final step, increased secretions in the spinal cord to increase sensory up, descending inhibition of spasticity down, increase descending motor down to get these areas to move. 40 and 10 was still there to keep the pain down. Unit number 3 was still running scarring and inflammation in the nerve and the dura when the movement caused an increase in chest pain. And then unit number 4 was still 40 and 89. So that was the end of the treatment at day 1. So we were 3 hours of treatment on day 1, about an hour of history, 10 minutes of chat. So a little bit less than 3 hours of treatment at the end of day 1. Pain level was a 0. It was important to tell her that it would not last. She had Suboxone, she had gabapentin. My suggestion was that she take whatever meds she needed to make the pain tolerable when it came back. And then we'll see where you are the next day. The pain went up to a 6 out of 10 that night, but didn't go up until about 9:30 or 10 o'clock at night. She took pain meds, and to tell you the truth, the spinal cord stim unit has been off since that day. So we are aware August 3rd, 2nd, someplace like that. So it's been a month, and the spinal cord stim unit has still not been on. Pain was down to about a 2 out of 10 until 9:30. And what happened is that she went to bed about 9:30, and she played on her tablet and hung out on the internet until midnight. Well, that involved tucking her chin. If you've put your iPad up on your thighs and played on the internet in bed, you've got neck flexion. So the pain did increase from the feet up. It went up to about a 5 or a 6 out of 10. Occiput was sore. Intercostal spaces were tight. Her chest was tight. She described heel cords, and her ankles hurt because her Achilles were so tight. It's interesting, the people that had described this to her described heel cords as if the Achilles were intrinsically tight. Well, in point of fact, the Achilles would loosen if you run 81 and 10. She woke up very stiff, but the pain went away faster than it usually did. The stiffness went away faster. Breathing was different. When she coughed, she felt like her ribs were opening up, and the coughing created an increase in rib pain. So the stiffness that she described, if you have loss of the descending inhibition or a little bit of spasticity, neck to feet is 81 and 10. To get the pain down from 6 out of 10, we ran 40 and 10, both of these, unit 1 and unit 2, 2 units in 1 towel at her neck and 1 towel at her feet. Unit number 3 was run from the spine at T1, from T1 to the sacrum, and like in a hand towel, and then from the clavicle to the pubic bone on her chest and her abdomen, and we just ran 40 and 396 to get that nerve pain down, and then scarring in the nerve, scarring in the dura, to treat those tissues for scarring and to improve mobility. So if you're going to cough and you have adhesions between the nerve and the fascia of the nerve and the periosteum and the ribs, that's going to increase the rib pain. And the ribs are in quotes because what it really is the intercostal nerves. So quiet down the intercostal nerve pain with 40 and 396. Treat the scarring in the nerve and the dura with 13 and 396 and 443. And then unit number 4, back and abdomen with little washcloths. Concussion protocol again, midbrain subacute, and 40 and 89. And then I ran the GI section on the auto care. So these, unit number 4 was an auto care, GI section and the small intestine and abdominal adhesions. That's to deal with the abdominal migraines, right? I think I threw in or added on this unit radiation in the small bowel, radiation in the sympathetics, and radiation in the nerves. So that was the setup on day 2. After the pain was a 0 out of 10, the patient was disoriented again. So I did 40 and 89 on unit number 4, that auto care, and then I ran the midbrain subacute. If you look at the frequencies on the summary sheet for that, you'll see why I did that, so to treat her poor little thalamus so it could catch up to present time. And then I just pushed the hold button and kept the auto care on 40 and 89. Neck pain, the unit number 1 did 40 and 94 to quiet down her upper trap, scarring in the dura, torn and broken on the ligaments. Imagine how many falls she's had in 29 years. Unit number 1, again, scarring in the cord, scarring in the dura with trunk rotation and flexion, and gradually increased her range of motion. As her range of motion increased, she had pain in the sacrum and the coccyx that was eventually reduced and then eliminated as we treated with her seated. Was flex, forward, rotate her trunk, side to side, side bend, side to side, sit up, wait for, 30 seconds, scarring in the dura, scarring in the cord, scarring in the dura, scarring in the cord. It took about 20-30 minutes, but she was able to flex forward, touch her toes while seated. And when she was able to do that, her ankles hurt. She pointed to her ankles. And if you could see her gait, the spasticity in the Achilles just slams her toes into plantar flexion, just slams her foot into plantar flexion. And if you look at the motion that's created by that spastic movement, the talus just goes sliding forward, and just the talus was effectively subluxated in both feet anteriorly. Now, before the spasticity was gone, it didn't matter because that's what her foot always did. So I used an activator. It's an adjusting instrument. Physical therapists could mobilize the talus, but it's pretty difficult. the activator just resets the proprioceptors, so it moves the joint itself without having to do it mechanically. So after the adjustment, her ankles didn't hurt anymore, the ankle pain was better, and the motion of the foot was more normal. She could actually dorsiflex and stand normally with her feet flat on the floor. Unit number 1 was once again set to 81 and 84, increased secretions in the cerebellum to coordinate things, increased secretions in the spinal cord to send descending motor, increased secretions in the sensory cortex with trunk movement, and I created some resisted trunk movement by having her rotate into the resistance of my hand and activate the deep spinal rotators, flexors, and extensors. So we did all ranges of motion in the trunk with slight hand resistance, and that worked out really well. Pain was a 0 out of 10. Motion and gait were more normal, and the muscles were fatigued, obviously. These muscles haven't worked normally in 30 years. So that was the end of the treatment at day 2. Day 3, pain came back again to about a 6 out of 10 at night, around 9:30. Body and hip pain was about, well, that's a 5 out of 10, not 5 out of 20. That's pretty funny. 5 out of 10. The stomach pain was 7 out of 10. So abdominal pain was 7 out of 10. Is it the abdomen or is it the nerves? So the pain diagram that she filled out that day was the back of the head, the upper trap, the right ribs, both heels, and her feet. And then she mentioned, coincidentally, she vomited that morning. And I said, how did you happen to vomit? So, well, I took the elevator down to pick up the luggage cart from the hotel lobby, then came up from the lobby and went, took the cart to the room because we had to change hotels that day. This was Friday now. And she said, yeah, this kind of vomiting happens 4 to 5 times a year. It was random, just she got back up to the room, went directly into the bathroom and lost her breakfast. She wasn't nauseous before the vomiting, but after the vomiting, her stomach hurts and she was nauseated. So clues for the vomiting, okay? This is not a functional medicine, dysbiosis, food allergy kind of vomiting. This was the elevator, right? So if you have a vestibular injury, you're going to take an elevator down, there's no horizon. And I asked her about riding the elevator. It suggested to me that there may be a vestibular problem or contribution to this vomiting and this nausea that she gets. Oops. Sorry. So I questioned her about the trip to the lobby. She took the elevator down, she took 2 right turns to pick up the cart, and then the elevator back up, and 2 right turns to get back to the room. No nausea at that point. She just entered the room, made it to the bathroom, and vomited. The nausea started after the vomiting. So no GI cause of vomiting in that circumstance makes sense, right? But I had to rule out a vestibular cause for the vomiting. So I did Weber's, and it lateralized. She heard it on the right only. Fields of gaze were seriously saccadic to both the left and the right. Air conduction was aversive and very bothersome to the left ear, pretty normal in the right. The vestibular questions you get in the core seminar. She doesn't like crowds, doesn't like Costco, doesn't like movement, doesn't like lots of movement in her visual field. Only odd thing was she read well. Well, at this point, she was still nauseous after vomiting. The nausea didn't start, had trouble keeping her eyes open, would not make eye contact just because focusing and concentrating was difficult. I had meclizine in my purse because I seem to have developed many years in the last 3 or 4 months. So I was carrying meclizine with me, and I always had it in the office anyway. So I gave her 25 milligrams of meclizine or bonine, and about 40 minutes later, the nausea was gone. So same setup as before. Her body pain, mind you, is what did I say, a 6? Yeah, 5 or 6. 40 and 10, neck to feet, 81 and 10. She's tight, sort of spastic. Now the spasticity is just increased tone. It's not spasm like muscle clamping. It's just increased tone. So the muscles they're described as tight. You're not seeing a spasm like a jerking. It's just increased tone. 81 and 10 will take that down. Back to abdomen, 40 and 396 for the rib and abdominal pain. If you vomit, you're doing a very exaggerated and instantaneous Valsalva, 40 and 396, and that Valsalva would stretch the nerves and create abdominal pain, 40 and 396 to get that down. Back to abdomen. We did the concussion protocol again. There's nothing like getting motion sick and barfing to, create a concussion. At 30 minutes now, the stiffness was gone, and I switched. The stiffness seems to be going away faster than the pain. Unit number 2, I took that unit from 81 and 10. Since the stiffness was gone, I put it from her neck to the back of her head and top of her head to treat scarring in the dura and torn and broken and trauma and inflammation or hyperactivity. 44 is the frequency for the inner ear. So 44 is the one advanced frequency that we ran on her. Then 40 and 89 neck to head to get the central sensitization down. So this is, once again, Friday was 3 hours. Then I moved the patient to a seated position that kept 40 and 10 on one unit. That unit number 1 always ran 40 and 10. Unit number 2, seated trunk flexion, increased secretions in the cord, the cerebellum, and the sensory cortex with active flexion. And as she flexed forward, heading sort of to be able to touch her hands for her feet, created sacrum pain medial to the SI joints. So treating the dura just one time is not going to completely remove adhesions in the dura that have been there for 30 years. So because the pain was medial to the SI joint, she said, it feels like it's on the inside of my sacrum. Okay, we have a frequency for that. Scarring in the periosteum, 783, scarring in the dura. What is it? What's wrong with it? So the sacrum pain is on the inside. What's there? What's there is the periosteum on the inside of the sacrum and the dura, 443. Increase or decrease inflammation on the periosteum, and that got rid of that. Then unit number 2 was, once again, increased secretions in the spinal cord, the cerebellum, and the sensory cortex to sort of get her connected to her body. She had full range of motion, pain-free, and she was pain-free. So I had asked her mom on that first day, could they afford 2 custom cares, because I didn't know any way that we could treat her with one. And they said, we have a fund for her that is for just things like this. And since it had worked in the office 3 days in a row, we dispensed 2 custom cares, one that was programmed with 40 and 10, the other one was programmed with 81 and 10. We gave her wraps for neck and feet and clips. So the next step, the last step in all this, was to see if they would work to keep her pain and stiffness down. So pain went up to 6 out of 10 with walking from the car into the hotel, and she fell. The spasticity makes walking very problematic because she just moves awkwardly. She treated with the units last night, got her pain to 0. It only took 30 minutes. Pain diagram she filled out on this Saturday was the spine, along the spine, the ribs, the anterior thighs, and both ankles. Head is okay. She had no headache and no neck pain. The most important part was that she woke up really stiff and tight, but pain-free for the first time in 30 years. So spine from her neck to the tailbone feels tight. Her pain went up to a 4 out of 10. Walking from the car into the office. The stim unit had been off since Wednesday. She takes CBD to keep the inflammation down. That's a cannabinoid oil that is anti-inflammatory, anti-tumor, has no THC and no psychoactive effects. So she took that last night, and it was the first good night's sleep she'd had in years. She did take buprenorphine last night and this morning to avoid withdrawal, and that was as instructed. I think she might have reduced the dose a bit. Unit number 1 was neck to feet, 81 and 10 to reduce the stiffness. Mind you, she had no pain, so we just needed to reduce the stiffness. 81 and 10 took the stiffness down, scarring in the cord, 13 and 10. And then spine to groin, scarring in the dura, scarring in the nerve, and scarring in the connective tissue. If you think of connective tissue between the dura, the nerve, the cord, and the spinal column, you get an idea why I ran 13 and 77. I did that while she's supine with hip flexion. Headache was gone, the spine and hip stiffness was gone. The Achilles was tight and tender and thickened. So unit number 3, which was a precision care, I put it on her left and right Achilles, and for about, 30, 40 minutes ran torn and broken in the tendon, torn and broken in the periosteum, because effectively what she had was Achilles tendinitis and tendinopathy. Once the thickening was down and the pain was down, I did scarring in the nerves for the nerve sprouting that Dr. Musnick talked about in his presentation. We're going to run a little bit over time. Sorry about that. The talus was uncomfortable when we dorsiflexed her foot, and once again just bumped the talus back where it belonged. So that was kind of fun. Day 4, I dispensed 2 custom cares, one that had 40 and 10 in the first position. The other one had 81 and 10 in the first position, and then both of the units were otherwise the same, 27 programs on each unit. Nerve pain to be run from spine to abdomen for the rib pain. Scarring in the dura, scarring in the cord, used with movement or the notes, so she could increase her own range of motion. Cord fix is a protocol to try and treat the tracts in the cord to make the effects more lasting. Coordinate movement is the title on the subject line. Increase secretions in the cerebellum, increase secretions in the sensory cortex, increase secretions in the cord. Concussion protocol, and she was told that it's not really just for concussions. The note said to use it at least once a week or anytime she has a fall or any emotional stress. Sleep, Achilles tendon repair, PTSD to be run as needed just when the crazy thoughts come back. So the PTSD protocol. I heard back from her, she's run that about 4 or 5 times, which I find interesting. Delayed onset muscle soreness. As her muscles start to move more, and as she starts to exercise with less spasticity, these muscles that haven't moved normally in 30 years, she's going to have some post-exercise muscle soreness. Muscle strain in case something happens. Low back pain, a combination of facets and discs. So I took the subacute facets, subacute discs, and just combined it into about 1 40-minute protocol, deleted 284, and just made everything sort of 40 and a little bit of 91 with facets and discs. Sciatica for that left leg pain, neck pain, facets, discs, torn and broken in the ligaments, scarring in the dura, knee pain, shoulder pain, heart health because she's 32 and she has had a lot of inflammation. That's also for her mom. Breast health because she's a 32-year-old female. Shingles because everybody gets shingles on their unit, whether they need it or not. Cold sinus, cold throat. Oh, there's a typo, Throat, cold throat. Bladder infections, 44 and 37, to help with the bladder. Also, she's supposed to take Bactrim or Septra or Macrodantin anytime she gets a bladder infection. And then the small intestine. So here's the follow-up. 3 weeks, a week later. So that last visit was July 8th. On the 21st, so 2 weeks later, she remains pain-free, sleeping well for the first week, adjusting to her new state of being, exercising daily, vigorously, swimming in a warm water pool, walking, going to physical therapy. She was off Cymbalta gabapentin and Celebrex, and she tapered off the buprenorphine by about 30%, and takes meclizine when she gets that nauseous or motion sick feeling, so now she knows what's causing it. She's got a medication to help. And after that first week, she said, I'm having trouble sleeping again. Well, she was concerned about that, and I said, well, you've gone off some Baltic, gabapentin, and Celebrex, all of which, well, at least the first two are going to make you sleepy. So give those about a month, and then we'll worry about sleep. And that appears to have resolved. So that's it. This is now we're August 2nd. I got another follow-up from her. She got a cold bronchitis that she picked up probably from so much swimming. And she was in bed. She just needed some rest. So she was in bed and took antibiotics and got over that. And then as soon as she could move, she got back into the warm water pool and started exercising. She is determined. So that is a really complicated, long case, right? But from an FSM perspective, it was really kind of easy. I needed 4 machines. I had to borrow one of them. But everything I did, except for the inner ear, was in the core seminar. I was lucky to have the units I needed. I had to borrow a machine to get the 4th one, but that was luck. I was lucky that we were lucky that the family had a special fund for her care so they could afford treatment and could afford 2 custom care units. It could not have been done. Maintenance could not have been done with 1 unit. You have to run both 40 and 10 and 81 and 10 at the same time. Lucky that she had such a strong and determined spirit. God, what an incredible kid. Lucky that her mom had kept her active and independent. She's still adjusting mentally and emotionally to being pain-free. It's like she's going to have to recreate her identity at 32. And that's going to take some time. I will see her again January 3rd and 4th, see how she's doing. She's lucky that she and her mom have such a healthy relationship, although they seem to be sort of revisiting adolescence because she's now experiencing a degree of independence on top of the dependence that she's had. So they have basically a healthy relationship, and they're good communication and deep affection, so that they are working through those transitions, and we'll just see. We are lucky that she vomited, and we found the vestibular problem on that 4th day or 3rd day, and also lucky that meclizine was sufficient for the nausea. So it was an amazing case. She sends me updates about once a week, and she's doing great. Her pain level never gets above a 4. She runs the unit as soon as her pain goes up. She's using it about twice a day. I don't know that it will ever be lasting, just because. We'll see. We'll find out in January if she's still needing it twice a day. But just the fact that she can get herself out of pain and get the spasticity down is just extraordinary. So there we go. Masterclass, upcoming events. FSM Masterclass is September 9th and 10th. That 2nd weekend in September. It's a small group FSM learning and practical experience. Class size is limited to about 15, maybe 16, even numbers. Every class is different. We sometimes have patients come in from the outside. Sometimes we just treat whoever's there. So you treat what you find and understand what you're doing and why you're doing it, and learn to think about what we do, how to think about what we're able to do, kind of like this last case. What causes what, and what do we have that can change it? It's going to be in McMenamins Kennedy School again. I love it. We're not going to be in the big gym. We're going to be in a smaller meeting room. They have great food, lovely, unique rooms in the Kennedy School. It was a grammar school in 1910. They have a hot soak pool. They have free movies at night. This is one of my favorite classes. It helps if you've been to the advanced because we're going to be using that laminate, but it's not essential. The FSM core seminar is now 4 days. Jacksonville will be there September 21st, 22nd, 23rd, and 24th. Chicago is October 26th through 29th. We'll be in Nuremberg December 1st through 4th. That protocol, that core seminar is, I think, 1,200 euros. Is that correct? 1,240 euros, I think.
1,290.
1,290 euros, which makes it a bit expensive on the FSM side. But if you want to go to Germany and have a deductible trip, that would be good. They have an advanced seminar the following weekend. I don't think that is on the website, and I'm not sure what he's charging for that. Do we have the advanced on there? So that's going to be mostly me for 2 days, 3 days, I guess. It is simultaneously translated in English. I lecture in English. They translate into German. The notes are in German and English. Cleveland Clinic will be January 18th to the 21st, and it looks as if we will have Category 1 continuing medical education credit for the Cleveland Core Seminar in January. So MDs in the audience, if you want to get Category 1 credit, I think we will probably be approved for 26 hours. The core seminar is 28 hours now. We'll probably get 26, 24 hours of CME for it, for just that Cleveland class, because it will be co-taught by our Cleveland Clinic faculty. Phoenix, February 22nd, 23rd, 24th, 25th, that will be at Southwest College of Naturopathic Medicine. And then Portland, April 5th through 8th. Send a friend to the core, come back for a refresher and stay up to date. The core seminar changes just about every time I do it. It's pretty extraordinary. And it really is a 4-day event now. If you've only taken it once, the second time is much easier if that's any help. It'd be great to see you again for a refresher. The FSM Advanced 2018 is at the Crown Plaza, San Marcos in Chandler, Arizona. We were there a couple of years ago. It's a lovely event space. It's a lovely hotel. March 1st, Jay Shaw is going to come, and he's a physiatrist at NIH, and he's one of the world's top researchers in the area of myofascial pain and pain physiology and pain transmission. So I'm not entirely sure what his topic's going to be, but I will go any place and hear Jay speak just because I love his slides. They're just amazing, and he is such a wonderful, lovely human being. March 2nd and 3rd, the FSM Advanced course, hundreds of new frequencies, different treatment strategies, expert workshops, and your favorite speakers. The ones we know for sure, Dr. Musnick is going to be doing a 90-minute lecture that is an echo of the head injury, TBI, and TBI lecture that he gave at the IFM symposium this year. Paris Carbat, Dr. DiMartino, and others. I haven't finalized the speakers list yet. And then March 4th is the practicum instructor training. We had 15 people at the practicum instructor course last year, and those practicum instructors are just now helping out with the core seminars and completing their certification and their training, and we're very proud of all of them and very appreciative for their help. It is the practicum instructors that are going to carry FSM forward and make it possible for people to use the material that they get online in the textbook or in the DVDs. And then, just another reminder, the resonance effect. Spread the word about what you do, why you do it, how well it works, and get the word out about FSM. It's a page turner, to tell you the truth, and the reviews have been great, which is really fun. When I read it, it's kind of almost like somebody else wrote it. So here's what we're doing, changing medicine one patient at a time. Just think about what this girl will do when she finishes her bachelor's, becomes a therapist, and deals with chronic pain or disabled patients. How will she change their lives? And everybody that is trained to do FSM, every FSM practitioner, that includes you, the people that are listening, will change lives in a way that you cannot possibly imagine when you first took the core seminar. And changing even one patient's life changes the world, and that's what we're about. Great having you here. Glad the technical issues were much better this time. And we will see you, I think, at the end of August for our August webinar. Take care, do good things, enjoy the resonance.